Thank you so much for a very kind introduction. Uh, Lifetime management for TAVI. We know that the scope of TAVI is expanding all over the world, and even in the US data recently, it has shown that aortic stenosis, single AVRs has gone actually down, and the TAVI procedures have gone up. So, because we will be moving more towards the younger patients, as per the ACC guidelines, it's around 65 years of age. So they consider, because they live longer, so they consider whether many things for the lifetimes. There are a few things which I'm going to cover today, which is valve selection, coronary access, and conduction management. So when you're planning for younger patients and older patients, usually the outcomes you have to look are different. For younger patients, usually you look for hemodynamic and ppm mismatches, durability, coronary access, and future valve and valve. Whereas in older patients, you look for immediate outcomes, which is the mortality, stroke, quality of life, or any conduction disturbances. Although conduction disturbances are looked at for younger patients as well. So procedural consideration, we have limited options here, but you have to look for where you have got availabilities for balloon versus self-expanding valves. Each have got advantages and disadvantages, so you have to look into those. First thing, coronary arteries. So we know that there is a lot of prevalence of coronary artery disease with TAVI patients. And whether you choose PCI before TAVI or after TAVI, that depends on you. Although Abdul Wahab from Germany, he's a guy who works there, found that there's no significant difference if you do it either way. And there is another, which is the 2021 publication, which showed that coronary artery disease is prevalent and is independently associated with mortality as well. So you have to always think about that. Different criteria for coronary access. Next slide, please. It's not changing. Can you change the slide to the next one? Excellent. Okay, this one. So if you look, there are different criteria to look for which one are high risk patients, which one are low risk patients. The one on your left side is slightly complex, but the Jafar had simplified it, and he thinks that if there is a cusp height more than the coronary and VTC is less than 4, and the leaflet calcium is also different, then you have lesser chances of having any coronary obstructions. Although if your coronary osteas are very low, then the risk is quite high of obstructing them, especially considering that the STJ sections are very low as well. Once you have that, then you have to look for the valve, which valve you have to do and how much of the commissural alignment, because you need that in order for future access to the TAVIs as well. If you see, if the coronary osteas are less than these markers, I don't know if I can point towards it, but the ones... yeah, so it's not working. Anyway, so the bottom line, this red part, is basically the skirt of the each valves. And if the skirt, the ostium is below the skirt and there is commissure in front of it, then usually your risk of coronary obstruction is very high. Low frame heights, which is the sapiens on your right side of the screen there, is basically the valves which are balloon expandable. They've got short stents, and usually they are better for accessing the coronary arteries. This is our case which we did, and if you see, there will be a leaflet coming up once it inflates completely. And if you see, you can see in front of that that white segment in front of that coronary artery is the calcium bit. So once you deploy the valve, you will be very sure that this block, because STJs are very low, and that white bit is going to block your ostia. So for these patients, you have to consider doing in future any accesses, and we did actually chimney for this patient. Even in the CT scan analysis is very important. If you see the coronary ostium is very low for those as well. For future conduction defects, next slide, it's still not changing. Oh yeah, okay. So, oh, I don't know. They want to finish it, I think. Oh, here we go. Okay, so left bundle branch block conduction defects, very important, because once you get conduction defects, it associates your outcome as well. And if there is a left bundle branch block, so that you can be associated with progressive LV dilatation. And if even in partner 2 studies, even if they were not like with permanent pacemaker, left bundle branch block affects your outcome. And especially a QRS duration of more than 160 or equal to 160 post procedure is going to be a bit problematic. Permanent pacemaker again demonstrated that pacing-related LV dysfunction in post-TAVI patients, and also that PPM also delays the recovery of the left ventricular ejection fraction. So you have to make sure that you select the valves and in correct positions where you don't get these conduction defects. These are the comparison between different valves for showing pacemaker incidence. If you see that Medtronic has got a lot of incidence in it, which is the core valve initially was 25%, although with the cusp overlap technique they have reduced as well. These other valves are coming at the moment as well. We have got, I think in Pakistan soon we will have Allegra probably coming as well, which is biosensors are going to bring those. And the other one is the Hydra valve as well. They've got their own advantages and disadvantages as well, so you have to know about the valve frame before you deploy it. Future, again, if you're doing it in younger patients, they will need another valve in future, and for that you need to consider that a TAVI in TAVI is an option, or whether you do a surgical valve and the TAVI later on. It's up to you guys. But again, these have shown that these are feasible. Even a CE approval has happened to Medtronic recently for a valve in valve. Again, for redo TAVI, you have to look at the considerations, which valve goes first. Usually, internationally, you do a short frame valve first, which is the Sapien, and then followed by a high frame, tall frame, which is the self-expandable Medtronic valve. And these are different levels where you deploy those. So it says that if the outflow of the S3 is at the level of the fourth node at evolute, there's a 80% chance that you are okay. Whereas an evolute in evolute is pretty much a disastrous type of a situation. Valve in valve again. So once you're doing valve in valve, there's an app there on valve in valve aortic, which is you can download from Apple and Google as well, which is very good because it tells you the trifecta about the mitral flow and everyone, which one you can crack, which you can't crack. Trifecta you can't crack, I think the rest you can crack. And the technique is usually you attach an indiflator and a pressure syringe to it, and you do it. Some people do it before procedure. I think preferably do it after procedure because it can protect the AR, although it can damage your leaflets. So it's a choice between which the clinician makes. But these studies have shown that you can do it. Basilica is again another technique which can be used in order to protect your coronaries. And there is a lot of comparison data for Basilica with chimney. Basilica comes out to be very safe in experienced hands. Again, you have to also look for bioprosthetic valve dysfunction. There are different kinds of valve dysfunction: structural, which is within the valve; non-structural valve deterioration, which is like paravalvular leaks or around the valve; and then thrombosis and endocarditis and other features which you have to look for future. Comparison with TAVR and TAVI, durability is pretty much good for TAVI. There is data 10 years now available which shows the structural valve deterioration is higher in TAVR patients than in TAVI patients. They argue that this was trifecta in mitral flow, but then TAVI people argue that this was core valve in its early phases. So there's a lot of debate about these presentation of 10 years data. Structural valve deterioration, again, comparison of different, and if you see all these trials which were done, its TAVI comes out to be quite good actually. And even if it is not good in some of it, it is equivalent to the structural valve as well. So all these trials show that you can do TAVI for these patients and plan for future as well. Imaging for the lifetime management, again, halt is a phenomena where is hypotension. It happens if there is a thrombus formation within the leaflets. It can destroy your leaflet, so it's better to identify it, and you can check it with the echo gradients and also with the CT scan measurements, which can you get hypotenuated pictures like this. Antithrombotic management, this is post-TAVI. You have to give single antiplatelet majority of the cases, unless and until you check the gradients later on and they've got a bit of increased gradient or any halt on their CT scans, then you can switch to the anticoagulation as well. So summary is that TAVI is previously 80 years old or 85 years old. Getting TAVI is different from 60, 65 years old, 70 years old, or fit people having TAVI, because you have to think and tailor their treatment according to their requirement. Thank you so much.